Welcome to The Deep Dive, the show that extracts the most important nuggets of knowledge to help you stay well-informed and ahead of the curve in your professional life. Today, we're diving into the heart of modern medical practice, particularly within surgery. It demands far more than just exceptional technical skill, doesn't it?
It really does.
It requires an intricate dance, a profound connection between our medical expertise and, well, a deep understanding of the human being in front of us. This deep dive is all about navigating that vital, often complex, intersection. Our mission today is to thoroughly explore what we're calling the critical triad: the evolving nature of informed consent, the transformative power of shared decision-making, and the intricate psychology that underpins every surgeon-patient relationship. We'll examine how these elements don't just shape our legal and ethical landscapes, but fundamentally impact patient outcomes, satisfaction, and crucially, our own professional well-being as healthcare providers. For you, as mid to senior medical professionals, be it in high-stakes orthopedic procedures or routine consultations, understanding these dynamics isn't just theory, it's a daily reality that can truly transform your practice. We'll be pulling practical insights and cutting-edge perspectives from a stack of current research and expert commentary to ensure you're not just informed, but truly equipped to navigate these complexities. And to guide us through these fascinating layers, we're incredibly fortunate to have a leading expert joining us, someone who can synthesize diverse information and connect the dots with remarkable clarity.
Thank you for having me. It's a genuine pleasure to explore these crucial areas. The nuances of these interactions are indeed becoming ever more critical in our rapidly advancing medical field, and it's a privilege to share some insights with you today.
It certainly is. So let's unpack this by starting with something that might seem deceptively straightforward, but is anything but: the evolving landscape of informed consent. For many of us, informed consent might traditionally bring to mind a signature on a form, a legal tick box exercise almost, to simply obtain permission. But that's truly a narrow, perhaps outdated view in modern practice, isn't it?
Absolutely. You're spot on. The core concept of informed consent has really transcended that simple legal formality. At its heart, it's a fundamental ethical principle. It's designed to honor patient autonomy and, crucially, to actively facilitate shared decision-making. It's about ensuring patients truly grasp the proposed treatments, understand all the potential risks, the expected benefits, and, critically, the available alternatives. And in a truly comprehensive and meaningful way, think of it less as a one-off event, getting that signature, and more as a continuous, evolving dialogue.
A dialogue, I like that. And it's fascinating to see entire organizations dedicated solely to championing this, like the Center for Informed Consent Integrity, or CICI. Their monthly digest, which brings together so much current thinking, really highlights how broad and dynamic this field has become.
Yes, the ICI Digest serves as an excellent compass, really. It points towards best practices in governance, ethics, evidence, policy, and the practical application of consent. It meticulously aggregates and distills key content from a broad spectrum of peer-reviewed journals, and importantly, even includes crucial gray literature. The discussions happening before formal publication. What's particularly commendable about their approach, I think, is its inclusivity. They sometimes feature even controversial content. This isn't about promoting a single viewpoint, but about presenting a truly holistic landscape of evolving thought and discussion surrounding consent. It helps us see the full picture, warts and all, not just the consensus view.
That holistic view is so important, isn't it? Especially when we consider the sheer complexity in research and treatment today. My mind immediately goes to high-stakes areas like fetal therapy trials. The inherent uncertainties there must make the consent process incredibly dynamic and challenging.
You're absolutely right to highlight fetal therapy trials. A recent commentary really brought to light the immense real-world challenges clinicians grapple with in this area. Consent is constantly evolving. It has to, due to significant uncertainties, particularly concerning the long-term morbidity and mortality for neonates who undergo these interventions. So clinicians must continuously adapt the level of detail they provide about neonatal outcomes, even as the study progresses and more data becomes available. We're not talking about static information here. It's a living document, a living conversation. And for families, the potential burden is extraordinarily high. Think about the need for intensive at-home care or even lifelong renal replacement therapy for some survivors. It's huge. This necessitates consent discussions that stretch over days, involving multiple specialists to ensure every facet and potential future impact is thoroughly understood. The critical takeaway here, I believe, is that we need systematic collection of prospective data going beyond just the primary outcomes to fully characterize these long-term impacts and truly inform future consent processes properly.
That sounds like an immense emotional and practical load on families, requiring an extraordinary level of dedication from the medical team.
It really is.
And it sounds like longitudinal cohort studies, which can span years or even decades, present similar, if perhaps different, challenges over those extended periods.
Precisely. Long-term, large-scale studies face urgent and quite distinct challenges regarding informed consent. Traditional broad consent, where participants agree to future, often unspecified research uses of their data.
Right, the sort of sign here for anything later approach.
Kind of, yes. And even dynamic consent, which allows for more granular control over time, both have inherent limitations when research objectives inevitably evolve, or as participants' perspectives on data sharing change over many years. This is where a more nuanced approach, often termed trust-based informed consent, comes into play. The critical insight here is that it focuses not just on information disclosure, but on establishing and meticulously maintaining a foundation of trust with participants over the entire course of the study. This means enhanced institutional credibility, robust ethical oversight, and perhaps even regular reconsent procedures where appropriate to continually safeguard participant rights amidst the complexities of modern biomedical research. It's about a lasting relationship, not a single transaction at the start.
Building that trust over years, sometimes decades, that sounds like an enormous ongoing undertaking.
It is, but it's essential.
And speaking of sensitive areas that require profound respect for the individual, biobanking, especially with something as profound as brain tissue donation, must raise unique ethical considerations that even our most robust regulatory frameworks might not fully address. What do we need to consider there?
That's a really important question. Are our current regulations truly sufficient? Or are we playing catch-up? In the case of brain tissue donation, the unique technologies and the highly specific, often highly sensitive applications of these samples introduce ethical concerns that standard guidelines, even robust ones, may not fully anticipate. For example, questions around the ownership of derived data or the potential for future identification. These become incredibly complex. This highlights a pressing need for improved consent policies that proactively consider future uses, some of which might not even exist today, and crucially, align with donors' deeply held moral values and beliefs. It's about respecting the integrity of the individual, not just during their lifetime, but also posthumously. The broader research biobanking checklist is also a valuable tool here, designed to help us navigate the complex ethical, legal, and social implications, particularly in collaborative and transnational research contexts, where standards can vary quite significantly.
We've explored the profound ethical and legal frameworks governing consent, stretching from fetal therapy to the sensitive realm of biobanking. But all these frameworks ultimately rely on effective communication. So let's turn our attention to the immediate, tangible barrier in consent, the very words on the page. We often hear about how incomprehensible consent forms can be. Is that still a significant barrier, or are we making progress?
Oh, it absolutely remains a significant barrier and something we really cannot afford to ignore. A retrospective analysis looked at informed consent documents, or ICDs, and revealed that the median Flesch-Kincaid reading ease score, the FRES score, was a rather low 48.3.
Which is quite difficult reading, isn't it?
Exactly. To put that in perspective for you, documents with a FIST or US below 60 are generally considered difficult to read for the average adult. The critical insight here isn't just about making forms easier, it's that readability directly impacts patient engagement and even refusal rates. The study found a weak negative correlation between FRES and consent refusal rates, meaning less readable documents were indeed associated with a higher refusal rate. Makes sense, really. Furthermore, the expected duration of participation in this study also showed a weak positive correlation with refusal rates, suggesting that longer commitments can deter potential participants. In a busy practice, a poorly written form isn't just an administrative hurdle, it's a direct barrier to optimal patient care and can undermine trust before the proper conversation even begins.
That's a powerful, actionable link. The easier a form is to understand, the more likely patients are to engage with both the process and ultimately the treatment or research. So what are some of the practical solutions being explored to improve readability and efficiency in this critical process?
Well, we've seen some very promising developments in this area, thankfully. For instance, the successful development of a computer-based standardized consent form for laparoscopic cholecystectomy offers a clear roadmap. This kind of digital form significantly streamlines the process. It ensures legibility, a huge plus, removing handwriting ambiguities, making it inherently more medico-legally sound. Crucially, it aligns with GMC and Royal College of Surgeons guidance, often includes helpful visual aids like diagrams, and provides clear checklists for key risks. This approach has proven popular with clinicians, enhancing their confidence, and it serves as an excellent educational tool for trainees, ensuring consistency and thoroughness right from the outset.
Standardized, legible forms are clearly a step in the right direction for efficiency. But to truly engage patients, we often look to the digital realm, don't we? What happens when we empower patients to manage consent through their own digital portals? Does that lead to deeper engagement or just a different kind of hurdle?
It's a natural evolution, certainly. And an investigation explored precisely this: electronic surgical consent, or e-consent, delivered via patient portals. The findings suggest this can indeed significantly improve perioperative efficiency. By allowing patients to review and sign forms before the day of surgery, it can dramatically reduce those frustrating first start case delays, which, as you know, have a cascade effect on surgical lists. However, and this was truly fascinating and a critical insight for us as practitioners, most patients in this study still spent minimal time actually engaging with these digital forms. Seconds, often.
Really, just clicking through.
Pretty much. This underscores a pivotal point. While digital solutions enhance administrative efficiency, they absolutely do not diminish the enduring importance of direct surgeon-patient discussion and, above all, the foundational role of trust. The technology is a powerful adjunct, a tool, but it is never a replacement for that personal interaction.
That's a really insightful point about the human element remaining paramount, even with technological advancements. What about interactive multimedia interventions? Videos, animations, that sort of thing. Do they help patients truly grasp and retain complex information during the consent process?
Yes, there's been quite a bit of research here. A systematic review and meta-analysis on interactive multimedia interventions did indeed show they significantly improve immediate and short-term knowledge for patients undergoing invasive procedures. They can present complex information in an engaging and accessible way, making them a valuable adjunct to the consent process. However, and this is the crucial takeaway, the review also found that the impact on long-term knowledge retention, or on reducing anxiety levels, or even on overall patient satisfaction was not statistically significant.
So a short-term boost, but not necessarily a lasting change.
Exactly. And another experimental study further revealed that while interactivity did increase information retention, it was primarily for information that was previously queried by the patient. So if they asked about a risk, the interactive tool helped them remember the answer to that question. This suggests there are limitations to its overall impact on achieving truly informed consent across the board. The powerful takeaway from interactive multimedia is that while they are excellent for immediate targeted knowledge acquisition, especially for specific questions patients might have, they don't reliably translate to long-term understanding, reduced anxiety, or overall satisfaction. So they're a superb adjunct to streamline information delivery, but never a substitute for that deeper, personalized surgeon-patient dialogue that builds trust and addresses individual concerns.
It's clear that technology offers great promise for streamlining and supporting, but it fundamentally can't replace genuine human interaction and that deep conversation. Which brings us beautifully to our next major topic. Shared decision-making. This isn't just a buzzword in healthcare anymore, is it? It's truly becoming the cornerstone of patient autonomy in surgery.
It absolutely is. And what's fascinating here is that shared decision-making, or SDM, isn't merely a trend or an aspirational concept. It's increasingly recognized as the best model of clinical practice for genuinely patient-centered care. It signifies a crucial and necessary shift away from the traditional, often well-intentioned, paternalistic approach where the surgeon knows best.
The old model, yeah.
Instead, it cultivates a collaborative model. In SDM, the doctor and patient actively share the best available evidence, thoroughly exploring all the various treatment options together. The patient is then guided, not told, to make decisions that are deeply aligned with their unique preferences, their personal values, and their individual life circumstances. This is about empowering the patient to be an active participant in their own health journey, not just a passive recipient of care. It's a fundamental shift in mindset.
So it's about a true partnership, a mutual exchange of information and values. What would you say are the main pillars that SDM rests upon?
Fundamentally, SDM is built on three main interconnected pillars. Firstly, it's about ensuring the quality of care by tailoring it specifically to the individual patient. Secondly, it fosters true bidirectional communication and collaboration between the doctor and the patient, meaning both parties actively contribute and listen properly. It's a two-way street. And ultimately, the third pillar is striving for the patient's holistic well-being, acknowledging that health encompasses far more than just physical recovery. It integrates their life, their values, their future aspirations, and their personal context into the treatment plan, leading to decisions that resonate deeply with them.
That holistic approach sounds incredibly beneficial, not just clinically, but for the patient's overall experience. Are there tangible benefits we can point to, especially within orthopedic surgery, which is so often focused on restoring function and quality of life?
Absolutely. The benefits are well documented and quite compelling. Research consistently shows that implementing SDM in surgery significantly enhances a patient's understanding of their disease and the proposed procedures. It demonstrably increases patient satisfaction, improves adherence to treatment plans, which is key, and fosters a more realistic perception of surgical risks, which is crucial for managing expectations effectively. Furthermore, it has been shown to decrease regret, stress, and internal conflict when patients are faced with complex choices regarding surgical procedures. For orthopedic patients, this is particularly vital. We see a direct connection to patient-reported outcomes, or PROs, and their expectations.
Right. Those expectations seem key.
They really are. The fulfillment of those expectations is strongly associated with improved PROs and overall satisfaction. Similarly, positive expectations correlate with an improved postoperative quality of life, less pain, and reduced disability. This is incredibly relevant in orthopedic surgery today, where patients' expectations for active, fulfilling lifestyles post-joint replacement are significantly higher than in previous generations. They're not just hoping to be pain-free, they're expecting to return to activities like golf, swimming, cycling, maybe even running marathons.
That shift in patient expectations is profound, isn't it? Our patients aren't just looking for symptom relief, they're looking for a return to a specific quality of life. This forces us to ask some crucial philosophical and clinical questions.
It certainly does. This shift forces us to constantly reevaluate. What truly constitutes a good outcome from the patient's perspective? What is a realistic outcome given their individual circumstances? And crucially, who defines a good outcome in the first place? Consider the dilemma of a partial knee replacement that provides pain-free activity for 5 excellent years versus a longer-lasting but perhaps less functional total knee replacement that might limit certain activities the patient loves.
There's no single right answer there.
Exactly. Ultimately, the patient's perspective, their unique life goals and values, must matter most here, underscoring the fundamental principle of autonomy. It highlights why developing a healthcare system that fully embraces SDM is not just good clinical practice, but an ethical and moral duty, really. Even if some patients explicitly prefer a less active role in decision-making, which some do, the duty to offer and thoroughly facilitate SDM remains essential for evolving healthcare towards excellence and sustainability.
It sounds like an undeniable imperative, a non-negotiable aspect of modern patient care. Yet, despite these clear benefits, there must be practical barriers to fully implementing SDM in everyday surgical practice. What are the most significant hurdles we're currently facing?
You're right, implementation isn't always straightforward. One of the most significant barriers is, frankly, a pervasive lack of comprehensive knowledge surrounding SDM among medical professionals. It's often not adequately taught in medical schools or rigorously integrated into surgical training programs. It's seen as a soft skill sometimes, which is a mistake.
So a training gap.
Yes, and this deficiency directly leads to a communication skills deficit among surgeons. Effective SDM requires a specific, nuanced skill set. The ability to openly exchange both personal and complex medical information, to patiently allow patients to articulate their deepest values and preferences, and to skillfully facilitate deliberation between different options, all while rigorously preserving patient autonomy. Insufficient training in these specific communication areas can dramatically reduce a patient's desire to participate in their own care, which is entirely counterproductive to the entire aim of SDM. It creates a disconnect.
I can imagine time constraints are often cited as a significant barrier, too. Surgeons are already under immense pressure with packed clinics and demanding theater schedules. Does SDM truly add to that burden?
That's a very common perception, that SDM is inherently time-consuming. And whilst it might take a bit longer in the initial consultation, there isn't strong empirical evidence to consistently support that SDM always takes more time overall. Sometimes it saves time later by avoiding misunderstandings or complications. But it does highlight the need for healthcare systems to consciously prioritize and allocate resources for SDM, particularly for decisions that are highly dependent on patient preferences and where clinical outcomes may have significant individual variability. Furthermore, SDM is still often poorly addressed in existing clinical practice guidelines and consensus statements. There's significant heterogeneity in how SDM quality indicators are defined and measured, pointing to a clear need for more robust, standardized integration of SDM into guidance documents and medical journals. We need a clearer, more universally accepted roadmap for effective implementation.
So if we recognize these barriers and the need for a clearer roadmap, what tools and models are proving effective in promoting and facilitating SDM in the real world, helping clinicians overcome these hurdles?
Decision aids are becoming increasingly vital and sophisticated. These are tools such as carefully designed leaflets, informative videos, or interactive digital media, specifically created to supplement and enhance the patient-physician relationship. They provide clear, balanced information on treatment options, their benefits and their harms, and crucially, they help patients clarify their own values in relation to those options. For evaluating their quality, we have the International Patient Decision Aid Standards, or IPDAS, which provide a robust framework. IPDAS requires aids to offer comprehensive information on options, the probabilities of specific outcomes, and methods for helping patients clarify their values. This moves us towards sophisticated tools that don't just inform, but actively engage patients in their own decision-making process.
That sounds like a robust framework for developing effective tools. I've also heard mention of multi-criteria decision analysis models, or MCDA, in healthcare. Are these universally applicable for surgical decision-making? They sound quite technical.
They could be powerful analytical tools, MCDA models, but we must approach them with a healthy degree of caution, especially in life-critical situations. There's a crucial warning regarding the potential pitfalls of additive MCDA models for what's termed life-critical SDM, as they can sometimes be misleading and lead to counterintuitive recommendations.
How so?
Well, imagine a model adding up scores for different factors. To address this, Kujelski, Triantafili, and Yanas proposed a reasonableness test. It asks a very pointed question. Can a treatment that results in premature death trump a treatment that causes acceptable adverse effects? For example, if an MCDA model suggested a treatment with a very low survival rate was somehow preferable mathematically to one with higher survival but moderate side effects, it would clearly follow this reasonableness test.
Ah, I see, a common sense check.
Precisely. It helps us ensure that mathematical models don't override fundamental ethical considerations and patient values. Beyond these, there are established conceptual models like the option model, which guides clinicians through defining problems, portraying equipoise, meaning genuine uncertainty or lack of consensus on the best option, providing information, and supporting deliberation. Another excellent framework is the three-talk model, which breaks interactions into structured phases. Team talk for establishing shared purpose, option talk for exploring choices, and decision talk for reaching a conclusion. These provide clear frameworks for structuring SDM interactions effectively.
That reasonableness test certainly highlights the need for careful application of such models. It's a powerful reminder that at the heart of all these processes is the human relationship, particularly the deep psychology of the surgeon-patient bond. This isn't just about technical competence, is it? It's about building and meticulously maintaining trust.
Indeed. Trust is not merely a desirable quality. It is the absolute bedrock that underpins the surgeon-patient relationship and, frankly, all human relationships. Our General Medical Council explicitly mandates that doctors must make care of your patient your first priority and act with honesty, openness, and integrity, explicitly stating that we must never abuse trust. Trust itself is a deceptively complex construct, a shared belief that incorporates respect, vulnerability, and the ceding of control. It requires the patient to relinquish a significant degree of control, often suppressing considerable anxiety, with the profound expectation that the surgeon will act with both expertise, which is competence, and crucially, in their absolute best interests, which is beneficence. Earning and maintaining this trust is arguably the principal ethical obligation of the surgeon. Without it, the entire foundation of care crumbles, making effective treatment incredibly difficult, if not impossible.
That vulnerability on the patient's side must manifest in many different ways as they navigate such a profound, often life-altering experience. How do patients typically cope with this immense vulnerability?
Patients are inherently in a position of profound vulnerability when facing surgery. This can manifest in a wide spectrum of emotions: anxiety, uncertainty, fear, sometimes even anger, but also hope, gratitude, and occasionally almost an idealization of the surgeon. To manage these overwhelming feelings, they deploy various coping mechanisms, often subconsciously. You might observe avoidance, where a patient might internalize, "I'll think about the surgery later," simply to push the discomfort away, or outright denial, "I'm sure I don't really need the operation," even when the evidence is clear. Another common one is projection, where they might attribute their own fears or doubts to the surgeon, thinking that surgeon wasn't sure about the operation, didn't seem confident, when in reality the surgeon had complete confidence.
So they're projecting their own uncertainty.
Exactly. These are all subconscious defense mechanisms, as theorized by Freud, acting to protect the ego from overwhelming stress. Recognizing these patterns as a surgeon is absolutely crucial for effective, empathetic communication and for truly understanding where your patient is coming from emotionally.
That framework for understanding patient responses makes perfect sense and provides a valuable lens for us. And we touched on patient expectations earlier, but how do these expectations specifically shape perceptions and ultimately outcomes within the deep psychology of the surgeon-patient relationship?
Well, patient expectations have dramatically shifted over time, influencing both perception and outcome significantly. Take orthopedics again, for example. Patients now expect a largely active, fulfilling life after joint replacement surgery. They expect to return to specific activities like golf, swimming, running, maybe even competitive sports. This profound shift forces us, as clinicians, to ask crucial philosophical and clinical questions constantly. What constitutes a good outcome from the patient's unique perspective? What is the truly realistic outcome given their specific health and life context? And critically, who ultimately defines what a good outcome is? I don't quote. The dilemma of the partial knee versus the total knee replacement perfectly illustrates this. Which is better? It depends entirely on the patient's goals.
So the definition of success has become much more individualized.
Absolutely. Ultimately, the patient's perspective, their unique life goals, and their definition of what a successful return to activity looks like matter most here, underscoring the fundamental principle of autonomy. Fulfillment of these specific expectations is strongly linked to improved patient-reported outcomes and overall satisfaction, highlighting the profound psychological impact expectations have on the perceived success of an intervention.
This brings us to the surgeon's inner world. We often focus intently on the patient, but the surgeon's own psychology, their personality, their biases, their internal landscape must play a significant, if sometimes unseen, role in shaping that relationship.
You're absolutely right. It's a crucial, often overlooked aspect. It's important to remember that a patient, in one sense, only exists fully in the imagination of our own mind. They are perceived through the filter of the surgeon's unique personality, their past experiences, their education, their inherent biases, and their personal beliefs. This profound truth highlights the wisdom in Stephen Covey's advice. First seek to understand, then be understood. We need self-awareness. While individual styles vary immensely, some common crucial threads define the psychology of a truly effective surgeon beyond just technical skill.
What are some of those core qualities that, beyond the operating theater, make an effective surgeon, enabling them to navigate these complex psychological dynamics?
Firstly, and critically, emotional resilience. Operating under extreme pressure, making life or death decisions in an instant, and performing complex procedures that demand immense precision and mental focus requires an extraordinary capacity to manage stress. Effective coping mechanisms are absolutely vital to remain appropriately distanced from that relentless stress and, crucially, to avoid burnout in the long run. Secondly, leadership is paramount. Surgeons cannot operate alone. Their success is deeply dependent on the dedication, cohesion, and skill of multidisciplinary teams, nurses, physiotherapists, anesthetists, and numerous other colleagues. Successful surgeons are almost invariably highly effective leaders who can inspire and direct that team. Finally, and perhaps most profoundly, empathy and compassion. Despite the necessary emotional detachment required to make rational, objective decisions in critical moments, surgeons must never lose their empathy and compassion. This is the very basis for effective communication, for building that crucial trust, and crucially is what patients often remember long after the technical details of a procedure fade, especially when, inevitably, surgery sometimes goes wrong.
When things don't go to plan.
Exactly. The kindness of words, the gentleness of tone, the sense of being truly heard, these resonate deeply and can make a huge difference to how patients cope with adversity.
It's those human elements that truly resonate and differentiate care, isn't it? Which brings us to perhaps one of the most intriguing and subtle aspects of the surgeon-patient relationship: transference and countertransference. These are concepts often associated with psychotherapy, but they clearly have a profound, if often unacknowledged, role in surgical interactions.
Yes, absolutely. The psychodynamic framework, particularly the concepts of transference and countertransference, offers a powerful and deeply insightful lens for understanding and managing the complexities of the physician-patient relationship, including surgical ones. Transference is essentially the set of cognitions, effects, and motivations that the patient unconsciously experiences about the physician. It's often a subconscious transfer of feelings, expectations, and attitudes from a past significant relationship onto the present surgeon. For example, the surgeon might unconsciously remind the patient of a kind, authoritative parent, or perhaps a critical, dismissive boss from their past. This projection profoundly influences how the patient relates to and behaves towards the surgeon, whether positively or negatively, sometimes in ways that seem quite illogical on the surface.
That's a fascinating insight into the patient's unconscious mind at play. How can a surgeon, especially in a busy clinical environment, recognize and effectively manage these often subtle dynamics? It sounds challenging.
It can be. Diagnosing transference often involves a keen observation of both nonverbal communication, things like facial expressions, body posture, gestures, as well as verbal cues, which can be direct or indirect. Consider a hypertensive patient who is visibly embarrassed about not taking their medication, perhaps avoiding eye contact or speaking very apologetically. A perceptive physician might infer shame and a subconscious representation of the physician as a critical clinician who judges their adherence.
Okay, so picking up on those cues, then what?
Well, management strategies involve, firstly, affirming positive transferences, which can naturally strengthen the therapeutic alliance and build trust. If they see you positively, lean into that appropriately. For negative transferences, the approach is more nuanced. The clinician should first gently, verbally express the act of transference they perceive to confirm it with the patient. For instance, for that hypertensive patient, the surgeon might say something like, "I get the impression you might feel a bit embarrassed, perhaps as if I might be critical about the medication. Is that how it feels?" This opens a dialogue non-judgmentally. Then one might request proofs or specific examples from the patient, declare the reality of the current interaction to differentiate it from past experiences. Actually, my main concern is helping you manage your blood pressure effectively. Acknowledge any potential contribution the clinician might have made to the patient's perception and gently highlight similar past patterns the patient might have experienced. It's about bringing the unconscious dynamics into the conscious awareness in a therapeutic, supportive way.
And what about countertransference, the surgeon's own unconscious emotional and behavioral reactions to the patient? How does that manifest? And crucially, how can it be managed effectively, particularly in the high-stakes surgical environment?
Right. Countertransference is the reciprocal. It's a set of cognitions, effects, motivations, and behaviors that the physician experiences towards the patient. While it can certainly be a challenge, it's also a remarkably useful tool for inferring the patient's subjective experience and for identifying potential deviations from professional boundaries in ourselves. We can infer its source, whether it primarily originates from the patient's presentation or from the clinician's own internal dynamics, and classify its types. Concordant countertransference is when the physician identifies with the patient's self-representation, feeling similar effects. For example, feeling unusually anxious when a patient expresses profound anxiety about an upcoming surgery. Complementary countertransference is when the physician identifies with the object representation the patient has activated, reflecting the patient's perceived or expected behavior from others. For instance, that surgeon feeling unusually annoyed and critical of the hypertensive patient might realize they are subconsciously acting out the role of the critical, inconsiderate physician that the patient perceives or expects them to be, based on past experiences. That feeling of irritation is a clue to the patient's inner world.
So it's about the surgeon's profound self-awareness, recognizing their own reactions as potential data about the patient. How does one cultivate and manage that level of self-insight in such a demanding, high-pressure environment? It takes effort.
It certainly does. The management of countertransference involves several key techniques, which require significant emotional intelligence and ongoing reflection, perhaps even supervision or peer discussion. Firstly, self-insight. Simply knowing one's own feelings and thoughts in the moment is paramount. Surgeons need to regularly reflect on their emotional responses to patients. Why did that patient interaction leave me feeling frustrated? Secondly, anxiety management. This involves normalizing these often intense feelings. It's okay to feel annoyed sometimes and consciously choosing not to take the patient's behavior personally. It's usually not about you, it's about them and their history. Thirdly, empathy. Actively acquiring the patient's perspective, trying to understand why they might be behaving this way without over-identifying, particularly with concordant countertransference. It's about understanding, not merging emotionally. And finally, conceptualizing ability. Using psychodynamics theory, like transference-countertransference, to understand the patient's role in the interaction and how their past might be influencing the present dynamic. These techniques, though challenging, are essential to prevent the clinician from acting out of their own unconscious reactions and maintaining professional boundaries.
In rare cases where countertransference becomes uncontrollable and genuinely impairs the surgeon's objectivity or ability to provide optimal care, referral to a colleague becomes a necessary professional boundary safeguard. This is deeply human work, running alongside the technical mastery.
This truly adds layers of depth and complexity to the relationship, moving beyond purely clinical interactions. And these psychodynamic insights seem to align beautifully with broader ethical models for the doctor-patient relationship, pushing us beyond traditional and sometimes simplistic approaches.
They absolutely do. Emmanuel Emanuel's 4 models of doctor-patient relationships provide a highly useful framework for understanding this evolution in thinking. While the traditional paternalistic model, where the doctor unilaterally knows best and simply tells the patient what to do, is now largely outdated and ethically questionable.
Awfully outdated.
Hopefully. And the informative consumer model, which treats patients purely as clients and surgeons merely as technical service providers, just presenting options and letting the patient choose alone, tends to undermine the crucial foundation of trust we've discussed. The deliberative model really holds the most promise for modern practice. In this model, doctors and patients are truly equal partners in shared decision-making. It combines information with values clarification. It has the best evidence for patient satisfaction because it respects autonomy and aligns care with the patient's deeply held values. But crucially, it also implies that patients must own some responsibility for their health choices, informed by that shared understanding. This brings us to some complex contemporary dilemmas that illustrate these models in action.
And one of those dilemmas that's highly relevant in orthopedic surgery, and indeed across many specialties, is the issue of obesity, which carries significant implications for surgical outcomes. How do these ethical models grapple with that really tricky issue?
Absolutely. The issue of obesity in orthopedics presents a powerful ethical tightrope walk. It's undeniable clinically that obesity clearly impacts surgical morbidity and complications in procedures like total knee arthroplasty. It increases risks of infection, wound healing issues, anesthetic complications, implant longevity issues, the list goes on. This raises a critical and often uncomfortable ethical dilemma. Is it discriminatory to refuse or defer surgery solely on the basis of a patient's weight?
A really difficult question.
It is. This question intersects directly with the body-positive movement, which advocates for acceptance of all body types and broader societal embraces of diversity and inclusivity. We must be incredibly careful not to stigmatize patients based on their weight. However, we must also counterbalance this with our fundamental social responsibility to allocate finite healthcare resources effectively and ethically, aiming for the best possible outcomes for the largest group of patients. This leads us to question the ethics of performing high-risk, potentially low-benefit surgery in morbidly obese patients, where the chances of a truly successful, long-lasting outcome may be significantly diminished, potentially tying up resources, theater time, beds, follow-up that could benefit other patients perhaps more significantly. It's also vitally important to acknowledge that obesity is often closely linked with complex societal issues, including poverty, socioeconomic factors, access to healthy food, safe places to exercise, and mental health resources.
So it's not always just a simple matter of individual choice.
Far from it. This means patients may not have had the equitable opportunities or support needed to attain a healthier weight. These are not simple questions with easy answers. They are deeply entangled in complex clinical, ethical, and societal issues that demand careful, individualized deliberation, often involving multidisciplinary teams.
It's a powerful example of how deeply personal medical decisions can become entwined with broader societal ethics and the allocation of limited resources. As we navigate these complexities, it's vital to consider special populations and the future directions of healthcare. How do the principles of informed consent and shared decision-making apply to particularly vulnerable groups, starting with young persons, adolescents?
Protecting vulnerable populations is absolutely paramount, and adolescents represent a unique challenge. For young persons, particularly in health research, there's a delicate and ongoing debate around adolescent consent. Some views frame adolescents as inherently vulnerable, suggesting they require extensive protection and parental oversight. This perspective can sometimes lead to what's termed gatekeeping by ethics committees, where potentially valuable research involving adolescents is held back unnecessarily. Conversely, an empowerment approach emphasizes their developing capacity to make decisions, recognizing their growing autonomy and the importance of involving them directly in decisions about their own health and research participation.
Finding that balance must be tough for ethics committees.
It really is. They sometimes struggle to strike this balance effectively, occasionally resulting in tokenism, asking adolescents for input, but not really listening, rather than genuine participation. A specific, highly relevant issue here is adolescent self-consent for vaccines like HPV. Allowing adolescents to consent for themselves, without necessarily requiring parental permission, depending on maturity and local laws, of course, could significantly increase vaccine uptake and foster greater personal autonomy in health decisions, aligning with that empowerment approach. It's about finding that sweet spot between protection and promotion of autonomy as they mature.
But that's a challenging area where nuance is essential. What about patients experiencing chronic pain, where decision-making capacity might fluctuate or be particularly difficult to assess clinically?
This is an area of significant concern and ongoing challenge in practice. A pilot study on decision-making autonomy in chronic pain patients revealed a rather stark discrepancy between clinical perception and objective assessment. Clinicians often overestimate patient autonomy in this group. In this particular study, physicians assessed 89% of patients as having full capacity to consent. However, when assessed using the MCAT tool, which is a structured clinical interview systematically assessing understanding, appreciation, reasoning, and ability to express a choice, often considered a gold standard for measuring consentability, it showed a much starker reality.
What did it find?
It found that only 48% had no cognitive deficit impacting their decision-making, and a significant 26% showed major deficits that would likely invalidate consent if not addressed. This highlights the considerable challenge in accurately assessing capacity in a busy clinical setting, particularly for patients with complex conditions like nasoplastic pain, where cognitive function can be subtly affected by chronic suffering, fatigue, and medication side effects. The crucial insight is the need for perhaps more routine use of objective assessment tools in complex cases, and certainly greater awareness amongst clinicians of these potential hidden deficits, rather than relying solely on clinical intuition, which can clearly be misleading.
That's a powerful statistic highlighting the gap between our clinical intuition and objective measurement. And for persons with dementia, PWD, and assisted living communities, where balancing safety and autonomy can be incredibly difficult daily, how are these principles applied?
For persons with dementia, or PWD, in assisted living communities, the challenge is immense and constant. Communication strategies commonly deployed, such as watchful oversight, redirecting behaviors, and reporting concerns, are often put in place with the very best intentions, primarily to ensure safety. However, these methods, while aiming to prevent harm, can inadvertently and significantly compromise residents' autonomy and well-being.
Could you give an example?
Well, for instance, redirecting a resident who repeatedly says they want to go outside might keep them physically safe within the building, but it fundamentally overrides their expressed wish and can cause significant distress and frustration. This calls for a much more nuanced, person-centered approach, balancing safety with empathy, implementing clear, formal policies on residents' rights to make decisions where they still have capacity, even if fluctuating, and providing comprehensive, ongoing staff training. That training should foster a more supportive and respectful environment that preserves as much autonomy as possible, meeting residents where they are in their journey, even in the face of cognitive decline.
It sounds like a deeply personal, human-centric approach is needed for each unique situation, really listening.
Exactly.
And how do broader cultural and historical considerations, particularly for Indigenous women, influence surgical choices and the consent process itself? That adds another layer of complexity.
This is a crucial area where understanding historical context and cultural values is absolutely essential for ethical practice. For Indigenous women undergoing breast cancer surgery, for example, studies have shown that while breast-conserving therapy, BCT, and mastectomy generally have equivalent survival rates, American Indian Alaska Native women often undergo a disproportionately higher number of mastectomies. This disparity raises serious questions about whether their preferred surgical choice is always being fully explored and facilitated. Is there equal access? Are preferences truly heard? Informed consent here must go beyond the standard clinical discussion of risks and benefits. It must actively incorporate additional historical and cultural considerations, things like historical trauma related to medical systems, specific cultural beliefs about the body, community support systems, geographical access issues to ensure truly equitable access to their preferred surgical choice, free from implicit biases, systemic barriers, or historical factors that might influence their decisions or, crucially, their trust in the medical system.
So it requires proactive cultural humility from the clinical team.
Precisely. And expanding this further, the right to free, prior, and informed consent, FPIC, for Indigenous peoples, is a fundamental right, recognized internationally, particularly relevant in contexts like green transition projects, wind farms, mines that might affect their traditional lands or ways of life. This ensures they are genuinely involved in decision-making at all stages, preventing what's sometimes called green colonialism, where environmental projects disregard indigenous rights. It's a powerful reminder of how broad the implications of truly informed consent can be, far beyond the individual patient in the operating theater.
That's a powerful reminder indeed of how broad the implications of consent can be. Let's shift our gaze now towards the future. How is the increasing digitalization of healthcare and the rapid rise of artificial intelligence impacting informed consent and patient autonomy? Feels like a huge wave coming.
It certainly is. The big data age fundamentally challenges us to rethink informed consent as we've known it. With countless companies, not just healthcare providers, collecting vast amounts of personal health data from wearables, apps, genetic testing companies, genuine privacy self-management becomes incredibly difficult for the individual. Who controls all this data?
It feels almost impossible to track.
It does. What are the solutions? Well, they're still evolving, but they could include more robust ethics committee review of consent practices specifically tailored to data usage, more intuitive visual consent agreement, maybe using graphics or videos for better transparency, and the development of sophisticated privacy software that aims to give individuals more granular control over who accesses their data and for what purpose. We're seeing promising developments like South Korea's My Health Hub, a dynamic consent-based application for personal health data sharing, which aims to give individuals more control. However, inherent concerns about security, data reliability, the potential for misuse, and digital literacy gaps still need very robust addressing.
And what about the ethical challenges specifically posed by AI when it's integrated directly into clinical care, perhaps assisting in diagnostics or treatment planning?
AI introduces a new, complex layer of ethical considerations right at the point of care. Key challenges include ensuring robust data privacy. Where does the AI training data come from? Mitigating inherent algorithmic biases that can unfortunately lead to inequities in care if the AI is trained on skewed data. And critically, ensuring patient autonomy in what we call technology-mediated patient care. As AI systems become more integral, helping read scans, suggesting diagnoses, predicting risks, we need to establish a clear right to notice and explanation for any AI system used in healthcare.
So patients know when AI is involved and basically how it works.
Exactly. This isn't just a technicality. It aims to fully inform and educate patients about how AI is being used in their care, promote trust in these systems, which is vital, and ensure they meet our established consent standards for truly informed decisions. It's about making sure that as AI becomes more integrated, patients aren't simply subjects of algorithms, but actively understanding consent to their use. Furthermore, the increasing influence of biometric technologies, facial recognition for check-in, voice analysis, continuous monitoring whilst often focusing on laudable goals like efficiency, effectiveness, safety, and security, can inadvertently contribute to patient marginalization if not carefully managed. Think about access, bias, data security. Innovations in this space must actively promote equity and agency, ensuring technology serves the patient, not the other way around.
It sounds like regulatory guidance needs to adapt incredibly quickly to keep pace with these technological advancements and the ethical complexities they introduce. What are we seeing in terms of policy development to address these evolving needs? Are regulators keeping up?
Well, they're certainly trying, and we're seeing a clear and necessary regulatory shift towards genuinely patient-centered approaches. The FDA Patient Engagement Advisory Committee meeting, for instance, specifically focused on patient-centered informed consent in clinical study of FDA-regulated medical products. The overarching goal there is to make consent forms far more understandable and to significantly increase participant comprehension of key research elements, moving beyond just simple readability scores towards true understanding. They've also issued draft guidance on incorporating voluntary patient preference information over the total product lifecycle of medical products. This demonstrates a broader regulatory shift towards systematically integrating patient input throughout the entire life cycle of medical product development and use, not just at the beginning. This signifies a real commitment to patient voices being heard throughout.
And are these significant changes happening globally, or are they largely confined to specific regions like the U.S.?
No, this is very much a global movement, reflecting a growing international consensus on the importance of these principles. The WHO guidance for best practices for clinical trials is a prime example. It was developed specifically to strengthen country-led research and development ecosystems worldwide, particularly in low and middle-income countries. This guidance complements existing international standards like ICH GCP and focuses on universal ethical and scientific principles, with a particular emphasis on ensuring the inclusion and protection of underrepresented populations in research. It's a testament to the global recognition that these principles, robust consent, ethical conduct, patient focus, are universal and foundational to good healthcare and research everywhere.
Finally, let's consider a powerful, real-world example of how new legislation intersects with patient and family autonomy. The Organ Donation Deemed Consent Act 2019 here in England. How has that opt-out system actually played out in reality since its implementation? Has it worked as intended?
The Organ Donation Deemed Consent Act 2019 in England, which introduced a soft opt-out system, provides a compelling real-world case study of the complex interplay between law, ethics, and profound human emotion. Despite the legal framework of deemed consent, meaning consent is assumed unless someone has opted out or is in an excluded group, families can, and often do, still override the deceased's potential or deemed wishes at the critical moment. It's soft because the family discussion remains central. This leads to quite variable outcomes. Studies have shown only about 37% of families provide full support for donation under this system, while 49% give partial support, agreeing to some organs but not others perhaps, and a significant 13% decline donation altogether on behalf of their relative.
So the law hasn't automatically translated into more donations in every case. Why are families overriding?
Several key reasons emerge. Some families express confusion about what deemed consent actually means in practice. Others perceive organ donation itself as a harm to the deceased's body, perhaps due to cultural or religious beliefs. And critically, at a deeply emotional and vulnerable time, families sometimes prioritize their own utility, their own grief, their own wishes, their need for closure over the deceased's expressed or deemed wishes. This suggests that simply changing the law isn't enough. There's a persistent need for ongoing sensitive public education campaigns to foster greater understanding, address concerns, normalize conversations about organ donation within families, and build broader societal support beyond just the legal framework. It's a powerful reminder that human emotions, cultural beliefs, and deeply held values can, and absolutely will, shape outcomes, even in the face of legislation.
That's a truly thought-provoking insight into the complex interplay between law, ethics, and deep human emotion and cultural beliefs. We've navigated the intricate pathways of informed consent today, from the critical importance of legibility and digital interfaces right through to the profound impact of trust-based approaches over time. We've explored the transformative power and, let's be honest, the practical challenges of shared decision-making in surgery, understanding its core pillars and the tools available to help us. And we've delved into the deep psychological currents of the surgeon-patient relationship, unveiling the crucial roles of trust, those ever-present expectations, and the often unconscious dynamics like transference and countertransference. These aren't isolated concepts, are they? They are interwoven, indispensable threads in the very fabric of exceptional medical practice.
Absolutely. And what's truly fascinating, and perhaps the most important takeaway as we wrap up, is that as we look to a future where AI, advanced robotics, and even more sophisticated digital tools will undoubtedly play increasingly significant roles in healthcare, the essential human touch, the empathy, the compassion, the active listening, and the unwavering commitment to truly understand our patients' unique psychological landscapes, their values, their preferences, that human element will only grow in its irreplaceable value. The technology will undoubtedly advance, offering amazing possibilities, but that profound human connection, that therapeutic relationship, will remain absolutely central and non-negotiable for truly effective, ethical, and satisfying care.
That's certainly something profound to ponder, isn't it? How will you, in your practice, continue to cultivate that profound human connection in an ever-evolving technological landscape? If this deep dive has sparked your curiosity or offered valuable insights for your practice, please do consider rating and sharing this deep dive with your colleagues. Your engagement really helps us continue to explore these crucial topics. Thank you so much for joining us today.